This is First Pediatrics. Hi, everyone, and welcome back to First Pediatrics. I'm Chris, and I'm joined by Hunter, who is one of our current third-year child neurology residents at the University of Michigan. Hunter, can you share a little bit more about yourself?
Definitely. Like you said, I'm a third-year pediatric neurology resident at the University of Michigan. I'm originally from the East Coast, but lived all over. And at the end of my training here, I plan on pursuing an epilepsy fellowship.
That sounds really great, Hunter. Given your experience, do you want to tell us a little bit about our topic today and why you think it's important for learners?
Yeah. So in this case, you are cross-covering a patient who is admitted for seizure capture and they have a prolonged seizure. And I know for me, the first time I responded to a seizure alone, it was really scary. And so I wanted this episode to discuss how to approach this scenario so that when you show up to the room, the expertise you're bringing will bring calm to the room, but also help stabilize the patient.
I think this is such a fantastic topic to discuss. Could you also remind our listeners about our podcast?
Sure. So First Pediatrics is a peer-to-peer podcast geared towards pediatric resident education. Our goal is to address your first management experiences by bringing you evidence-based content to help you on the wards and make daily life more manageable as a resident.
Thanks so much, Hunter. Do you want to go ahead and get started with the case?
I would love to. So, Chris, imagine you're at the end of a busy night shift on the inpatient wards and you receive a page from a nurse that, quote, bed 1260 is seizing. Please come to bedside. On your way to the room, you read in the handoff that this patient is an 8-year-old female with a history of developmental delay, admitted for seizure capture. She had her first episode the previous day and had been started on long-term EEG. What do you want to be doing while you're walking over to the patient's room?
First, I think it would be important to let your team know that you're responding. So having good closed-loop communication. I typically call the nurse to let them know that, one, I got their page, and two, I'm on the way. As you said, right, you have your handoff. I would be looking at that, trying to pick up things along the way. Some of those things can include, do they have a rescue medicine and dose that should be given if this truly is a seizure? I looked at the handoff and I can see that it says to give 2.5 milligrams of Ativan, which ends up being 0.1 milligrams per kilogram, max being 4 milligrams. And then also, I would want to see what other information I have about the semiology of their prior seizure to see if this is a change in the patient's status. We're not working alone as well, so I oftentimes will partner with any of the other residents I'm working with during a critical situation like this. I oftentimes have a plan in place on who might reach out to neurology if we are concerned this patient is having a true seizure.
Great. And it sounds like you had a lot of good information in that sign out. So when you walk up to the door, the nurse is at bedside with one of the technicians, and they thank you for coming so quickly. They state that the patient has been unresponsive for about 2 minutes, and looking at the patient, she is not responding, and she's having these diffuse tonic-clonic jerks throughout. The parents are not at bedside. What information do you want to obtain at the door?
First, I'd want to know when this started, and if this has not been done already, I would have someone start a timer so we could keep an eye on when to give the rescue medicines if needed.
So the nurse and tech were super on top of it. They've already started a timer. What are other things you're considering as you're walking in the door?
So a few other things I might consider with a seizing patient might be to first monitor their ABCs, so their airway, breathing, and pulse. So one, putting your hands on the patient and examining them will be super important. Then asking the nurse and tech in the room to help to put on a pulse oximeter, get a blood pressure, put on cardiac monitoring would be very helpful. Once that's obtained and started, you might then start to consider getting oxygen available if needed. So getting a nasal cannula in place or getting a bag mask ventilation setup available if needed. While typically I would suggest getting a point of care glucose for a patient that is seizing, since this patient is here for seizure capture, it's unlikely this is the cause at this time. Another thing that I oftentimes do is evaluate their access at the bedside. So see if they have an IV, for example, and if not, to consider trying to place an IV. The other thing that I can help out with, or anyone else on the team can help out with, is to actually click the button on the EEG to make sure that we acknowledge that the patient's having an event.
Chris, that is a great start. And as part of my training, one of the things that we get certified in is the emergency neurological life support protocol. And so some of the things they add to that initial workup of a seizure or initial management is going to be labs. So you can get a CBC, an electrolyte panel. You're really looking for those electrolytes. So getting a calcium level, magnesium, a venous blood gas is going to be another place because you'll get your electrolytes back really quick. And then other important considerations are getting a pregnancy serum test for females in the childbearing ages. And then also getting anti-seizure medication levels in the event that this patient has been on medications before. And while you don't always need to obtain labs in otherwise healthy children, and probably not in this case, but I just wanted to acknowledge this protocol since it's an important consideration to have. What other things can you be doing for the patient while they are having convulsions?
Well, you can work with nursing to get the head of the bed elevated. You could also place the patient in the lateral recumbent position to help with secretions and to maintain the airway. While the mechanism of elevating the bed to help out the patient is sort of unclear, 73% of sudden unexpected death in epilepsy occurs in the prone position, so make sure that they're not face down. If padding has not been applied to the bed, these can be put in place to avoid trauma. Also, if you have enough support, it might be helpful to have someone go to let the family know what's going on, since I think I remember they're not currently in the room, right?
Yeah, that's right, Chris. What might you be saying to the family if you were not the primary doctor taking care of the patient? How might you share this very scary information?
I would first look in their chart to find their primary contact, and when I call them, I would state my name and title. I've otherwise unfortunately had families hang up inadvertently thinking it was a spam call if I didn't state my title right away. I would say, "This is Dr. Demas. Is this Erica's mother?" For example, if the patient's name was Erica. It's really best not to assume who you're talking to. Then I would ask to confirm the patient's date of birth. So I might say, "I'm calling to give you an update on Erica's status. Could you confirm their date of birth for me first?" Then I would share the reason I'm calling. For example, I might say, "Unfortunately, we're concerned that she's having another seizure at this time. She's currently stable and we're giving her IV medicines to stop the seizure. But I wanted to call you to see if you or someone else would be able to return to the room. Do you have any other questions for me at this time?" What do you think of that, Hunter, as a start?
That sounds really good, Chris. It's hard to anticipate every situation, but let's say this is the second time she has ever had a seizure, and the family is in the room and they're clearly distressed by the situation. You know that the patient is here for seizure capture, so it was expected that they might have a seizure, but it's still hard to watch. What might you do in this situation?
So if this was your primary patient, or if maybe you're a standby secondary provider, it would be really nice to introduce yourself and make sure they know who you are. Sometimes I like to ask if they have any questions about what's happening, if you'd like me to explain anything about what we're doing. And then sometimes families like to just be there with their son or daughter. And also sometimes they need to step outside of the room. So it's important to meet the family where they are.
I completely agree. And I also think it's important to make sure that the family isn't left out, because sometimes I've been in these situations where the family's at the side of the room and nobody's attending to them. So if you're a provider who has education around this situation and you can comfort the family or potentially like pull them out of the room, I completely agree with what you're talking about.
I love that, Hunter.
Okay, so now the nurse tells you the glucose has come back. It's normal. You do have IV access. The patient has maintained her airway. She is afebrile. Her vital signs are all within normal limits. Since the patient is stable, you use this time to perform a neuro exam. What are you looking for on the exam?
So first and foremost, I would look to see if you can get the patient's attention or if they're unresponsive. Hunter, do you have an approach on how to do this?
I do. So getting the patient's attention can be a progressive process. So first I start by calling their name. Then you can apply some pressure, shake their shoulders. If this doesn't work, then try something more noxious, such as nail bed pressure. Make sure when you're doing the nail bed pressure, put like a pin behind their nail, something sturdy, so when you're applying the pressure, they will actually feel it. Other things you can try are trap squeezes, so squeezing behind their neck, or lastly, a sternal rub. If the patient does not respond, it is more likely that this is truly a seizure. And if the seizure is big enough to encompass both sides of their body, they will by default not maintain their consciousness. After I've tried to get the attention of the patient, it is important to look for focality on your exam. Chris, when looking at the eyes, what could you gather if the patient had a blown pupil or pupil irregularity?
Yeah, since this patient is actively having a seizure and is altered, I would have more concern about this and would be especially concerned about a more severe intracranial cause of the seizure and might even prompt me to think about contacting neurosurgery and getting a CT scan, for example.
That's really important to consider, especially a first-time seizure if they've come in the setting of trauma. Luckily, this patient has had no blown pupils. There's no deviation of the eyes to suggest focality either. Then next, what I'll look at are the movements themselves. Do they fit the semiology that was written in our sign out? In this case, they do, but then I'll check for suppressibility. So I'll feel the movements and see, can I make them stop?
Since if they're suppressible, they're less likely to be a true seizure, right?
Yeah, that's right, Chris. And if I'm looking for focal features, I do look for the eye deviation. I look for dramatic head turning to the left or stuck on the right. I look for asymmetric limb posturing. And while this might not prompt any changes in my imaging, it is an important thing to note for further management of the patient's seizures in the future. I want to take this time to also bring up factors that favor seizure. So, ictal factors that favor seizure include cyanosis, so like blue discoloration of the lips and gums, frothing at the mouth, and the absence of pallor. Postictal periods are also a universal factor where following the episode, the patient will often be disoriented. And then other features you can expect to see in seizures include aching muscles because their body just ran a marathon. And then a unique finding to seizures that's commonly seen is lateral tongue bites.
I think the information about what to look for during a seizure is really helpful. The other thing I like to think about is the common mimics of seizures. Would you mind chatting a little more about that?
Yeah. So while there are several mimics of seizures that one can commonly see, they generally don't last as long as this one is lasting. But one that we commonly see in pediatrics is psychogenic non-epileptic seizures, which is a behavioral manifestation that looks very much like a seizure. And common features can include a gradual onset. So it slowly begins and then it ramps up. And then it's discontinuous. It'll go away for a little bit. It's irregular in nature. Or if there's any asynchronicity, so like they're not rhythmic motions. Also, if the patient's head is rolling side to side, that would require the seizure to jump between hemispheres of the brain. Pelvic thrusting is a very complex movement that I would not expect. Opisthatonic posturing, so that famous picture of the man with tetanus poisoning, that is what you should have in your mind. That is also more common in a psychogenic epilepsy. You can also see stuttering. They will often have their eyes persistently closed, and some patients may even weep. Another one that is commonly mentioned by specialists at our hospital is they're generally close to the ground. They don't cause trauma to themselves. They'll either fall on a bed, or they'll be on a couch, or they'll already be seated in a chair. Okay, Chris, at this point, it is 4 minutes into the seizure. I have 3 questions. When would you call the status epilepticus? When would you give your first line PRN? And then thinking further down the road, at what point can a seizure cause neurologic damage?
Ooh, a lot of good questions. I would call this status if the patient had generalized seizures lasting greater than 5 minutes, or focal seizures with impaired awareness, or an absence seizure that's greater than 10 minutes. And that's more of just like the definition. Since this is a patient that's having generalized tonic-clonic convulsions, I would give Ativan that is ordered for them. And I would do that after the 5-minute time frame. And then many sources point towards 30 minutes of seizure activity where neurologic injury can occur. But I want to also point out that while injury is more likely after 30 minutes, it's certainly not guaranteed. And thankfully, most come out okay. Some families become really terrified knowing this 30-minute time mark and are under the impression that brain injury will happen after 30 minutes, and that's not necessarily true.
I'm glad you're pointing that out. Let's make this more difficult. Let's say the patient's moving around, they dislodged their IV. What do you have as options to abort the seizure?
So Hunter, knowing that children can receive abortive medicines at home without an IV that have epilepsy, this is not super atypical, but in the hospital, I typically reach for intranasal midazolam. The dose is 0.2 milligrams per kilogram, or twice the dose of IV Ativan, given intranasally with a maximum dose of 10 milligrams. And, since we already know what the dose was for the Ativan, you could hypothetically in your mind just double that one if you had it on your paper, for example. Other alternatives include rectal diazepam, midazolam, buccal, or IM.
So the technician says that it is 5 minutes since the episode started. You tell the nurse to give the abortive medication. What will you be watching for during administration?
So you want to think about the side effect profile of any medicine when you give it. And for benzodiazepines, the typical and common side effect that can be concerning is cardiorespiratory depression, and specifically watching their breathing. So I would want to make sure that we had, good monitoring that we're already doing, and watching their oxygen saturation and just watching their breathing quality.
Great work. And while it's not a side effect, another thing to monitor is increased secretions, because you could have the nurse suction those. Unfortunately, this administration of the abortive did not make the seizure go away, and the patient continues to have seizures. There are no changes in the patient's vitals. What do you want to be thinking about at this time?
So I would want to be thinking about a second-line medication, Hunter, and I would also want to start thinking about escalating care to the ICU. I am not a neurologist, so oftentimes I will plan to reach out to neurology to see what they would consider the next line medicines, but you could always consider giving another dose of benzodiazepine, and I typically would do that at the 10-minute mark. Do you have a typical approach for a second line medication?
I do, and there's actually research to support this. So for a second line medication, you can give several medications, which I would hope that you could discuss with neurology, but there's some times where neurology is going to be busy with something else and you have to make a choice. So in children, several good options include phosphonatoin, that's 20 milligrams per kilogram, you can give it IV. Keppra or levetiracetam, that's a 60 milligram per kilogram load. Valproic acids, also known as Depakote, can be loaded, and that is 40 milligrams per kilogram. And then finally, phenobarbital, 40 milligrams per kilogram, can be used via the IV. Since pharmacy can take a while to get these medications to bedside, I would order at least one of them. In this case, I would order the Keppra, 60 milligram per kilogram, since it is a generally safe seizure medication. And I know I mentioned research. In the ESET trial, which is a paper in the New England Journal of Medicine, they determined that children older than 2 years of age, given any of these medications, there's generally no difference in efficacy of the fosphenytoin, levetiracetam, or valproate. It's good that you're thinking of those next steps. The patient's respiratory status starts to change, and you notice that she's making more gasping sounds, sound almost like hiccups. Should you elevate the level of care?
I would definitely do that at this point, and I would have our nurse call a rapid response team to the bedside to help escalate care to the ICU and get an ICU provider at this time. If the patient started to take a turn for the worst, meaning concerned about them being able to breathe and manage their ABCs, I would call a code at that point to expedite care to the bedside to make sure that we are getting the right providers there in time. And especially given this change in respiratory status and the continued seizure activity, they might need intubation and also potentially an infusion, such as a midazolam drip or a propofol infusion to help abate this seizure.
So the PICU fellow and the rapid response team arrive at bedside after the nurse has given the second dose of Ativan. The levetiracetam has also started infusing. The patient continues to have convulsions. How would you discuss this patient with the PICU fellow?
So since I'm worried about the stability of this patient, I would discuss in the patient's room and try to do it as succinctly as possible. I would start by saying that this is an 8-year-old female with a history of developmental delay who is currently admitted for seizure capture and was found to have a generalized tonic-clonic seizure that began roughly 15 minutes ago. She's now status post 2 doses of Ativan at 0.1 milligrams per kilogram and a loading dose of Keppra at 60 milligrams per kilogram without successful resolution of the seizure. Labs so far that have been obtained include a point-of-care glucose, electrolytes on a VBG, all of which were within normal limits, and the exam is notable for no response to pain stimuli and movements are not suppressible. There are also new changes in the respiratory status with gasping breaths, but maintained oxygenation. I would also indicate our reason for calling the rapid response team would be to discuss the need for intubation given the new change in respiratory status and the need for possible anti-seizure infusions in the ICU given refractory status epilepticus.
I like that you're calling this refractory status epilepticus because after failing the first and second line medications, this falls under the category of refractory. And the PICU evaluates the patient and agrees with your plan. Great job calling the intubation. What helped you make that decision?
So some of the standard indications for rapid sequence intubation in a patient that is experiencing status epilepticus, it does include things like an unprotected airway, concern for apnea, hypoxemia, or like we were talking about earlier, status epilepticus that is lasting greater than 30 minutes, which is in that danger zone. So there's a few things with this patient having early signs of concerns for developing apnea or respiratory effort declining, and also that this episode is now lasting 15, maybe going on 20 minutes, and it's unclear whether or not we're going to have resolution within this next 10 to 15 minute time period.
Excellent. So the PICU fellow agreed with your plan, and the patient was transferred to the pediatric ICU. They underwent rapid sequence intubation and were started on their midazolam infusion. Fortunately, their seizures went away within 30 minutes. So great job managing this acute complication on the inpatient service.
Yeah, thanks, Hunter, for leading us through this case. So in terms of the takeaways from this episode, I hope you'll feel more confident in managing acute escalations in pediatric care, such as seizures. When notified of care escalations, make sure you go directly to the bedside and request nursing to obtain vital signs. When you arrive, monitor the patient's ABCs and ensure stability. If the patient is unstable, at that time, call a code. If stable though, begin a timer and place the patient in a safe position, which is either the head of the bed elevated or in the lateral recumbent position, and make sure to avoid the prone position. Next, when you examine the patient, assess for focal signs such as a blown pupil, eye deviations, or a change in the seizure semiology. Recognize signs that are consistent with a seizure, such as checking for unresponsiveness, noting any frothing at the mouth or cyanosis, and whether they're post-ictal or have a tongue bite after the conclusion of a seizure. Be aware of possible mimics of seizures, such as psychogenic non-epileptic seizures, which may present with the ability to answer questions during the episode, discontinuous movements, head rolling, pelvic thrusting, or weeping. Make sure to familiarize yourself with the first-line seizure medications, such as Ativan IV at 0.1 milligrams per kilogram if an IV is available, or intranasal midazolam at 0.2 milligrams per kilogram, which is double the dose you would give of the IV form. Rescue medicines should be given at the 5-minute mark, with a possible repeat dose at 10 minutes if the seizure persists. Monitor oxygen saturations and breathing quality closely when giving benzodiazepine, knowing the potential side effects. If the seizure does not resolve, consider consulting neurology for a second-line medication, but know that Keppra at a load of 60 milligrams per kilogram is both safe and effective. In addition, evaluate for the need for escalation to the ICU for potential IV benzodiazepine infusion and possible intubation. I want to thank Dr. Hunter Sheckley for being the content creator for this episode, and for our fact checkers, Dr. Jody Ehrman from Pediatric Hospitalist Medicine and Dr. Jared Mott from Child Neurology. Thanks so much for joining us on First Pediatrics, and we look forward to seeing you next time.